Okay.
Okay. Ladies and gentlemen, welcome back to our international ground round. Very pleased today to have a guest which is going to talk about pediatrics. And in this occasion, I have the pleasure to introduce the president of the Confederation of European Otolaryngology and Head and Neck Surgery. Good morning, Professor Meco.
Thank you very much. I'm very glad to join this session. Actually, this lecture is going to combine the pediatrics, but also with skull-based surgery. So it will be the skull-based surgery on pediatric population, which happens, and I'll try to show you how we are able to deal with the complex problems along the skull base through the nostrils, even in the very small children, which really preserves their growing bony structures. So we can go anytime you want.
Yes.
If you want.
So yes, please share your screen. Today's talk, in fact, is going to be finalized on pediatric endonasal endoscopic skull-based surgery. A reminder for all the attendees, please, as usual, you can type your question and we will go through each one of your questions at the end of the presentation. Professor Meco, please go ahead with your presentation. Thank you.
So thank you very much. Puya, it's a great honor to be in this webinar, to reach out your audience. So I'm a professor of otorhinolaryngology at Ankara University and Salzburg Paracelsus Medical University. And the topic will be pediatric endonasal endoscopic skull-based surgery. I have nothing to disclose, to tell, but being the president of the European Confederation of Otorhinolaryngology Head and Neck Surgery, using this chance, I'd like to invite all of you to the biggest event in our specialty this year in 2022 in Milano, the European Congress in Europe, from October 29th to November 2nd. Looking forward to meeting all of you there. So the registrations are open. There's almost more than 600 faculty already confirmed. The program is also published on the website. Please have a look. It's a great program. I can only recommend. Coming to the endoscopic skull-based surgery for the adult population, it became really the standard. Together with our neurosurgical colleagues, we are targeting areas beyond the skull base and beyond, using the intranasal corridor. Naturally, we have developed our skills. Nowadays, it becomes really the standard of care for treating many pathologies, and it enables important advantages in favor of the patients in the treatment of diverse and various pathologies. We are able to do maximal surgery through the nostrils and with comparable results to the open approaches without having facial incisions and osteoplastic techniques. For the pediatric age group, endonasal endoscopic approaches still pose a challenge to the rhinoendoscope. It's due to the small nares and nasal cavity, as well as inadequate pneumatization of the sinuses, which could hinder adequate manipulation in and around the skull base lesions. We know from the adult population that the distance between two carotid arteries, even in the adults, could vary between 11 millimeters to 25 millimeters almost. So this is also an issue for the pediatric age group, because the skull is definitely not the same. The sinuses are definitely not the same. It has a developing skull and sinuses, which the surgery should be really adapted. But the advantage would be, due to its less invasive nature, it could protect the developing bony structures of the face and the skull by avoiding skull incisions and osteoplastic techniques, as you can see, to reach to that especially central portion of the skull base. But more importantly, as we have already shown in the adult population, that we can significantly protect the olfactory system in comparison to a microscopic approach for pituitary surgery, for example. But the disadvantages would be the small nostrils, small nasal corridors, difficulty in manipulation of the instruments, sphenoid pneumatization, or its lack, or intraoperative blood loss and hemodynamic stability in the pediatric population. And of course, with the children operating on postoperative care and follow-ups would also be a little bit perhaps more difficult. Regarding the small nostrils, binostril working do really allow more space. And this is even better after 6 or 7 years old, because as you can see from the study from 2010, it has been already shown that the around 6 and 7 years, the sphenoid pneumatization comes nearly to the level of the almost adult ages, also with the anterior cellular wall almost. But this is and sorry, yes, and the intercarotid artery distances at the cavernous sinus and the superior clivus regions, as you can see, around 7 years of age, they become almost same with the adults. So this is a critical area, time, and almost 90% of the kids around 6 to 13 years age are a cellular type pneumatization. So as you can see here, we can do the surgery almost similarly like the adult population, but nevertheless, that is not this, the case in every case. This is a 13-year-old boy, where we needed a transplanum approach. As you can see, the pneumatization is not really complete to reach to the transplanum and pituitary region. So in those cases, we need to really drill out and find our landmarks, the both internal carotid arteries, the pituitary, the posterior wall of according to whatever we need for that specific surgery. But please have a look that there is some blood oozing in those patients. But as you can see, we can perfectly reach to the anatomical landmarks, so right and left internal carotid arteries and the pituitary, and then we can really resculpture the sphenoid to find our landmarks. Intraoperative blood loss and hemodynamic stability could be a problem due to these oozing. So we need to minimize and control intraoperative blood loss because the overall blood volume of the kids are less than the adult patients. But even in the absence of arterial high flow bleeding, the robust vascularity of the nose and sinuses, as well as the cancellous clival bone, can lead to oozing and substantial blood loss over time. So we but still some hemostatic agents where we can control these low flow bleedings. So we have done a study to reflect our institutional experience, including all kids except GNAs from 2012 to 2018, and we have really looked at all relevant data, and I'd like to share the results of that study for a moment. So there were at that time 54 patients with a mean age of 10.1 years, but the smallest one was 6 months, and the biggest one was 17-year-old. The biggest number of symptoms were visual loss and blindness after headache and growth retardation, but you can see also other ones. And as you can see, the biggest number of kids that we have operated was in percentage craniopharyngiomas and then pituitary tumors. But there are also CSF leaks and meningocele and other lesions, as you can see. This is a example of a pituitary case that we have done. As you can see, it's a cellular type cell, and that was very nicely operated and reconstructed after surgery. This is a 9-year-old male with a craniopharyngioma reaching very up to the third ventricle, as you can see, very high. And for those cases, we first start the surgery by doing a nasoseptal flap, because after the removal, especially with the third ventricle, we'll need to really reconstruct that area. So the pituitary is open, the planum is open, so you see the tumors. So we do, with a forehand technique, we dissect it. So first get its inside out, and then we dissect the sac from critical structures, neurovascular structures, and also dissect the capsule out. And this is what you see. This is the third ventricle inside, and we get inside with the endoscope with a this is a foramen Monroe. We can change the angle. This is the optic chiasm. This is the stalk. This is the pituitary gland chiasm and the anterior communicant arteries. Here you can see. And in such a case, it is also very important then to do the reconstruction. So this is definitely a multi-layer reconstruction. And at the end layer, we do a nasoseptal flap. So this is the same kid. The tumor is removed and she is neurologically intact, as you can see. But the case could be very difficult also, like in this 2-year-old kid where there is no sphenoid pneumatization. The kid came with amaurosis, very huge tumor, as you can see. Again, first doing the nasoseptal flap. Then we need to drill out all the sphenoid bone, and this is the planum, this is the sella, and then we first do our incision and remove all whatever inside the capsule tumor we have. Then after doing that, we start to dissect in a forehand. This is the optic chiasm on the right side, sorry, on the optic nerve on the right side, and this is on the left side. As you can see, with a forehand technique, we can dissect it from all the critical structures, and again remove the sac. And this is what we have. This is the olfactory bulbs. This is the A2s, the chiasm, and then we do again the reconstruction. So for especially craniopharyngiomas, this approach really is the best approach in our hands. And this is the same kid after removal of the tumor and the reconstruction, neurologically intact, but unfortunately the amaurosis didn't turn back for this. So regarding tumors, we achieved in almost 80% of the cases a gross total resection, and in 16% a subtotal resection, and the aim of surgery was a biopsy in 7%. Regarding the complications, in 11 patients we had a transient diabetes insipidus, and 2 of them temporary loss of vision. 1 patient had a pneumatocephalus 1 month after the surgery. I will come to that later on. And in 2 patients, we had panpituitarism and coronary sinus hemorrhage more than that we had before. Regarding serious morbidity and mortality, there was no meningitis or mortality due to surgery. Yet, in one patient, we had an endocrinological failure, and in the postoperative 15th day, we have lost the patient due to electrolyte imbalance and in hormonal deficiency in the Pico, although every measure has been done. Regarding the outcomes, visually, there were no change or visual improvements in 100%, so nothing went bad. Regarding the olfactory function, in the first 6 months postoperatively, the patients had almost 70% improvement or no change, and that raised after 6 months postoperatively to 97%, which is a good result. Regarding the CSF leak, we had a perioperative, so during the surgery, a CSF leak, which we closed, and only in one case, a postoperative CSF leakage, actually a pneumotus encephalocele after 1 month surgery. So just to show another approach, a transnasal approach for a craniopharyngeal canal meningoencephalocele in a 6-month-old male. This was the smallest kit that we have made. As you can see, the nasopharynx is completely obliterated by the meningoencephalocele, and the patient cannot breathe through the nose, but also the mouth breathing was hindered. And this is what you see inside. As you see, the nasopharynx is completely full and it's pulsating. And you can see that also in that 6-month-old kids, we have first done a nasoseptal flap. And then we have done a very small posterior septectomy, but preserved those bony chips for later reconstruction, as you can see. Then we start to dissect it from the surrounding soft tissues. This is the Eustachian tube on the right side. This is the nasopharynx. So we dissect also from the posterior wall with bipolar. And then after bipoling its stalk, we remove the meningoencephalocele, as you can see, and then here in its stump, after again coagulating, we have made, oh sorry, I wanted to show this one. We put a very small, in order to protect it from herniating again and opening, and for CSF rhinorrhea, we have put a metal clip. I will show it shortly here, as you can see. And we prepared from the bony chips that we get in a Surgicel, a layer that we pushed in there, as you can see. And then a small layer, and as the last layer, we put the nasoseptal flap backwards, and so the nasopharynx is open, and the nasoseptal flap covers the lesion. As you can see, this is the postoperative situs. The nasopharynx is open, nasoseptal flap is intact, and this is what we see. The nasal passage is open, and this is a transodontoid approach for basilar invagination that compresses the brainstem in a 14-year-old male. As you can see, through the nose, we can go transodontoid, get the C1 and the C2, the odontoid away, so that the patient has no basilar imagination, and of course do a stabilization beforehand. But that was actually the patient. We normally leave for secondary healing, but this patient had a very strong sneezing 1 month after, and had a pneumatocephalus. And so after that, we have given fluorescein and searched for a defect. But there was, even though there was no defect, we have had a nasoseptal flap done and posteriorly to cover that area, and the patient didn't have any problem. So also transcriptiform approach could be used for this meningoencephalus seal that really obliterates the nose. One can directly come and resect that from its stump and do a duroplasty, but one should really care for the frontal sinus opening. And as you can see, it is completely very nicely opened. One can also use a transfrontal approach. This is a 9-year-old boy who had a head trauma 3 years ago, 2 times meningitis attacks, and had a single-sided profound sensory neural healing loss after the last meningitis attack. As you can see, he had an active CSF area, which we had positive with the 2 transferrin tests. And this is from the surgery. As you can see here with the fluorescein, this is a bigger defect. This is from the ethmoids, a meningocele, and this is from the frontal sinus posterior fold meningocele. So we first resect the ethmoid one. As it's a very huge defect, we create a nasoseptal flap again. And then in order to reach the frontal sinus, we do a drop type 3 approach to the frontal sinus. As you can see here in the frontal sinus lateral, we have the meningocele. As you can see, we can then bipolar and resect that meningocele also, and then do a multi-layer reconstruction. Then we use an alloplastic material for this case, a couple of layers, and then as the last layer, we put the nasoseptal flap on. Even if it's the frontal sinus posterior wall together with the ethmoid roof, we can cover, as you can see, the posterior wall of the frontal sinus is also covered very nicely. And this is the postoperative 3 months of the same kid. As you can see, it is very well healed, and the frontal sinus is functional. And we also followed up this kid. This is the postoperative first year, very nice healing, no problem. But this is the postoperative 6th year. So the patient grew up from 9 years old to 15 years old. So as you can see, the pneumatization is perfectly developed, and this is our nasoseptal flap at the posterior wall of the frontal sinus. It is very stable even after years, and the pneumatization is going on. So we didn't really harm anything in the external skull of this kid. So, but if the leak is from a narrow supraorbital recess or far lateral frontal sinus, like in this 11-year-old female with a traumatic CSF rhinorrhea, you cannot really reach, even if you do a draft type 2B or type 3, to this very narrow recess. So for such cases, we do first a draft type 3 to have more place. Then we dissect the anterior ethmoidal artery and ligate it. And then after removing the lamina propria, then we can laterally suspend periorbita to create more space for manipulation and duroplasty in this region. As you can see, we cannot really work here, even if we do the draft type 3, but with the periorbital suspension. So we suspend it, or the Varese group calls this as orbital transposition. It's the same thing. We create a space that we can do the reconstruction. So this goes lateral, so that we can do our job there. So endonasal endoscopic approach is an effective method for surgery to manage various skull-based pathologies of also the pediatric age group. Due to its less invasive nature, it protects the developing bony structures of the face and the skull, along with sinonasal functions, while achieving satisfactory outcomes. Nevertheless, narrow transnasal corridor as well as inadequate sinus pneumatization could be the main handicaps of this approach in pediatric patients. So we also published this data that I showed you, but since then we also have now more than 80 cases actually, and I can really say that despite anatomy-related challenges in children, adequate results can be achieved with high rates of success, and the functional and anatomical integrity of the developing skull and nose of the children can be preserved. So I'd like to thank our multidisciplinary skull-based surgery work group back in Ankara. And again, would like to invite you to Milano this autumn from October 29 to November 2nd for Europe's biggest event for this year. But as you know, next year, we also have the ERS 2023 in Sofia. And for the ones who are interested, there are very nice courses. The next week, there will be the Copenhagen dissection course, where I will be also with. And next September, there is the endoscopic skull-based dissection course in Athens, and for the frontal sinus, which for many frontal skull-based surgery, it is needed. There is the very nice course on frontal sinus surgery in Nottingham in February. Thank you very much for your interest on this talk. So I'm ready for your questions if you have any. Thank you very much.
Thank you, Professor Meco, for the presentation. So, and thank you, of course, for the advertising for all these courses, which are very, very important nowadays, that we finally came back to reality and to normal life. So the suggestion is to replace and take care of the 2 years that we had, unfortunately, the possibility to improve ourselves. Let's start with the question, which are a lot of them. The first question is coming from Greece, in fact. Are the younger age would affect the worse outcome?
A younger age is a worse outcome. I have shown you, I mean, younger, I haven't operated, but I have operated on that 6-month-old kid. Even in that one, it is possible to manipulate within the nasal cavity with the endoscopes and with our principally standard instrumentation. Naturally, if you have some smaller ones, pediatric ones, it would be easier, but you know, the bigger problem would be if the sinuses are not well pneumatized, so you need to really drill more, and which means more oozing of blood and, you know, surgical time. So that could be some problem, but even as I've shown you, this is not a big problem at all, especially after 6-7 years of age. So if this is adequate, I don't know.
The second question is from Brazil, and in fact, is recollecting with your last sentence. Our colleagues from Brazil is asking, is the Lund-Mackay score valid for children?
Well, it is. Well, all of the cases that I have shown you are not inflammatory cases, which the Lund-Mackay score is really meant for. So in many or most of them, there are no inflammation at all in the nose, and we wouldn't like to have it also for a CSF leak closure or for a transplanum approach to the craniopharyngiomas or cellular approach to a pituitary tumor. So, I mean, we haven't really checked that, but I don't think so that it is valid or needed because there are no inflammation at all. So the CT scans of those cases are in all of them perfectly normal.
Other question is coming from Spain. Would a nasal septal flap or middle terminate manipulation impair olfactory function?
So as I have also shown you, and it is in the paper that we have also published, because we checked in that pediatric age group, of course, from the patients from 8 years old, I guess that was our limit, that we have done the olfactory tests, that in most of these cases, and I would say nearly in all of them, if not in some of them, a nasoseptal flap has been used, because for a craniopharyngioma reaching into the third ventricle, or after removing a pituitary tumor that the arachnoid is already open, as I've mentioned, in 50% of the cases, we had a perioperative CSF leak due to the tumor and manipulation in that area. So when you resect the tumor, you get that big defect. So you need to reconstruct that. But these are children. I mean, you cannot say that like in adult patients, please lie in the bed or don't restrain, or whatever you do, they will be afraid and they will be crying and doing all strength, which doesn't really fit with the healing, because we wouldn't like to have any compression or highness of the intracranial pressure. So in almost nearly all of them, if not in some, we have used the nasoseptal flap, and we have searched the data, what is happening with olfaction in the kids bigger than 8 years old. And as I have reflected and shown you the table, in within the first 6 months, the olfaction is normal or unchanged in almost 70% or 67% as now, as far as I can remember. But if you really continue to follow up those kids after 6 months, it comes to the level of 97%. So I would not assume that it really hinders their olfactory function, which is also in the adult population. We have done and published that in laryngoscope. So in comparison to the macroscopic approach, the endonasal endoscopic approach is really significantly better, preserves olfaction. But of course, as otorhinolaryngologists, during the surgery or while raising the nasoseptal flap, we are taking care of those regions that actually are important for the olfaction. So we are not unnecessarily removing the superior turbinate, or while preparing the nasoseptal flap, we are trying to preserve the upper portion of the septum, where the olfactory cilia are more predominant. So naturally, when this is something that we care and try to preserve, and according to that, our results show that we can preserve olfaction.
Other question is coming from colleagues. Osama is saying that the types of reconstructive materials, how you choose, our dear professor.
So the biggest workforce, especially for those cases with craniopharyngioma or with big, huge defects and in small kids, is the fascia lata and fat. So we do use some kind of a gasket seal, but not with cartilage or bone, but with fat. So we put as the first layer fascia lata, and like a gasket seal, we tuck it with inside with a fat, and then another fascia lata, and on top of that we put lay the nasoseptal flap. This is for these big, huge skull-based approaches that they are standard. But it is not the case if it is a traumatic CSF rhinorrhea, where the defect is probably much more smaller. And in those cases, in order to inhibit a second incision on the upper thigh to get fascia lata, we use alloplastic material, so like tuto patch. So I have no commercial interest. I can call the name. So that is what we have in the OR, in our OR. So for those kids, in order to protect, they will be also using their whole life their leg. So in order to protect them, we do use alloplastic material. But then, I mean, if there is too much pressure, like in the encephalocele, then in any way we're going to be putting on top of that some sort of flap, either nasoseptal flap, as in the case that I've shown you, or perhaps an anterior ethmoidal artery-based lateral flap, according to the case. So in between, then, if there is too much pressure, I have shown perhaps, but because of the fast telling the case, I haven't shown. We use a cartilage to take that pressure away from the flap, because I mean, the kids, you really cannot say that they shouldn't be really not straining or not giving pressure on top of the reconstruction.
And in fact, the next question from UK was exactly, are packing or splint recommended in pediatric endoscopic sinus surgery?
Yeah, actually, I mean, we do. On top of the nasoseptal flap, we put some kind of sponge gel, that will really dissolve from by itself. But we also put small cut fitted marrow cells with some glows on top of that, so that it's easier, because it's in case of any nasal bleeding, it is difficult to deal with the kids. So we put that for 4 or 5 days and then remove it. So yes, we do in our practice.
Another question, other few questions, then we are running out of time, so we're trying to make it shorter. From Russia, what are the postoperative advice specifically to pediatric functional endoscopic sinus surgery or skull-based surgery?
So I couldn't get the question exactly. So what?
It was, what are the post-operative advice specifically to pediatric endoscopic surgery?
Well, I mean, it depends how old the kid is. I mean, if the kid is not, really small, like 6 months or 2 years, or even 3-4 years, whatever you say, they're gonna do whatever they want. So that's the reason it is important to really use a nasoseptal flap, because by giving a pedicled vascularized flap on top of the reconstruction, we are making a jump in the healing. So we don't need revascularization. So the vasculature is already there. Healing will be much more faster. And then we have actually less toads. But if you don't use something like that, it would be very nice actually to have the head of the patient a little bit higher when they're lying down, and probably then I don't give iPad to my kids too much, but they can watch. You can try to sanitize them with some films or so that they watch something so that their concentration is on the screen, so they don't really run around. But otherwise, actually, it's pretty much the same what we are doing with the adult population.
Last question, and then we're good to go from United States. What are the latest innovation?
What is the latest innovation in pediatric skull-based surgery? So as a latest innovation, what I like is our navigation system can manage the augmented reality. So especially in the intracranial cases, where you go beyond the bony structures where we are very familiar, and as a tumor can really deflect the structures like optic nerve, or at the back the basilar artery, or A1s or A2s. Before the case, it takes really very short time, not even 10 minutes. I just mark them, I segment them, and then even I can sometimes use the what is actually meant for frontal sinus surgery, so that pathways. So I mark them, and then I can navigate the endoscope with that system. So it shows me with the endoscope, even if I use the angled ones, which area I'm looking at. And not on my main screen, but on the navigation screen, I can see then the structures that I have segmented beforehand, before I reach them. So if there is still some tumor, and if the basilar is behind that, as I'm coming from this side, I can see the reflection of it behind the tumor. So, I mean, I like it. It's some kind of a video game then. It gives it another layer of security, even though we really, if we don't have it, we can also, do it. But that's a nice innovation, I guess. So before reaching structures beyond the structure that I see, I can see those according to my marking, which most of the times one-to-one fits. So this is what I like. I like to do it.
Great, thank you, Professor Meco, for being with us. For anyone interested, you can type or you can email Professor Meco, I think, if you have any question, but I would advise anyone to join the seminars, the dissection courses, and the congresses organized in which he will be part of to discuss directly with him. Thank you, of course. Professor Meco was the latest of our guests for the 6th season, which is going to proceed further in October with the 7th season. And I would like to always thank our societies which collaborating with us, the European Rhinologic Society, the Italian Academy of Rhinology, the IACI, the European Rhinologic Society Juniors for the supports. And of course, I will looking forward to see everyone next year for the European Rhinologic Society meeting, and this year in Milan for the European Congress. Thank you, Professor Meco, for being with us.
Thank you very much, Puya. It's a great honor to address your audience. Looking forward to see you in person soon. If not soon, latest in Milano during the Confederation Congress, the European ENT Congress. Thank you very much for your attendance.
Stay